All right, Madalyn, just start off with just like a 30-second timeline of your dental career, from hygiene school basically to what you're doing today, just to give us an idea.
Okay, great, Mark. Madalyn Rosenbluth, clinically practicing dental hygiene since 1976. It's my 40th year of actively clinically practicing since graduating Miami-Dade College of Dental Hygiene. And I went to work for a world-renowned periodontist, a mentor of mine, and practiced in periodontics for 26 years. He's a great guy. In fact, he's 92 years old and is my father-in-law. And he still teaches at the university down in Florida. So anyway, I progressed to working with areas of gnatology for a dentist that was a gnathologist. I've worked for orthodontist, and currently, fast forwarding, now I work up in Hartsdale, New York, clinically for an aesthetic restorative practice. I had been lucky enough in the mid to late 70s to be introduced to a very dear friend of my father-in-law, my boss for 26 years, periodontist, Morton Rosenbluth's dear friend, Tony Rizzo. And in the late 70s, he would come into the office and he would actually became my patient, actually became another mentor of mine because he was evolving what we know as now ultrasonic inserts, the modified versions of them. He was one of the original engineers at the Tony Rizzo, excuse me, at the Cavitron Corporation in Long Island City, New York. But my, history is I began being a clinical hygienist for his instruments and evolving different designs, tweaking them here and there, testing them, always testing them, and then transitioning. During that same period I was working clinically, I was basically a consultant to Tony Rizzo, the original one and only Tony Rizzo, for over 2 decades until he retired and sold the business in the mid-90s. And I'm living in New York the last 14 years and, practicing, and I found a huge void in going to work in dental offices. They didn't have a quality of ultrasonic instruments or service in that area, and it frustrated me. And I had gone and talked to Tony about, what can we do to get this going again? And he goes, I'm retired. You have the intellectual property. You worked with me for decades. All the engineers. Go for it. And I incorporated MadUltrasonics in 2004, and the rest is really history.
Cool. So you obviously have the background for this, that's for sure.
The clinical drove the actual company of, MadUltrasonics. There was a need in the industry. As a clinically practicing hygienist all those years, I had seen a decline in the quality of ultrasonic instruments. Plastics came into play, resins. Nothing was made of surgical grade stainless steel. There were hygienists that didn't even know that there was a P-type instrument available. So, that was really the ideal preference.
Very good. So let's get into the business, Madalyn. Just kind of give us an overview of the products and the services you currently provide.
We have 9 different styles of magnetostrictive inserts. All can be seen on the website, MadUltrasonics.com. We have them available in 25K and 30K frequencies. We also have specialized grips for them, the Chubby's grips, that were also invented by a fellow dental hygienist, and we've been able to acclimate them to ultrasonic scalers, so it gives you the best of both worlds. The external water delivery system with an ergonomic silicone, surgical grade silicone grip. So our main area of focus is, of course, the magnetostrictive inserts. And we also do service of units, the equipment. We have 3 extremely qualified technicians that can service a 40 or 50-year-old ultrasonic unit, the big 660 gray box, those manually tuned, you know, I don't like to call them dinosaurs, but, you know, from the original days to the most recent generation of Dentsply. We repair all magnetostrictive units and hand pieces, foot pedals, all the accessories that go with it. We do also repair piezo units. Piezo units are a whole different animal. I won't get into it technology-wise, but they're very difficult to repair. We have a technician that works on them. A small percentage of our business is piezo tips, the sales of those. And that's the part of the business.
Do you know if most manufacturers offer repair service for their product?
There are a handful of repair people. I would say that most are sent out to independents.
Okay.
I really don't know a lot about the competition because I work with the original technicians from Tony Rizzo, you know, from the 80s and the 90s, and they're, you know, all, you know, our technicians, and they do a great job. We know that a lot of the competition cannot do the repairs, and if it is backed by a large manufacturer, they usually try and upsell the doctor to buy a new unit. And many of these units come to us with the original estimates and packing slips, and we're able to do the repairs with, you know, certified manufacturing parts.
And me personally, Madalyn, generally speaking, I'd rather deal with a smaller company. They just seem to have better customer service. I can't imagine trying to reach out to a big company, say my Cavitron or whatever is broken, and be like, you know, probably after 3 different people, finally get to somebody, you know.
You're absolutely right, and I am still clinically practicing, and we had that little test, you know, just very recently. I work for a large aesthetic practice in Hartsdale, New York, Dr. Solomon and Dr. Esposito. We have 5 dental hygienists, 5 hygiene treatment rooms, and I was on vacation, and they sent out a unit to, you know, the largest manufacturer of ultrasonic dental equipment probably in the world, and we all know the name. And I got back, it was 2 weeks later, couldn't find the unit. So, you know, these things happen with large companies. So when we did get back the unit, you know, I just said, what's with you guys? Did you forget what your hygienist does? You know?
Yeah.
So we have a very quick turnaround. We give free estimates. After we get an approval, it's back on the workbench and usually repaired and shipped out within 24 to 48 hours. And depending on what shipping the doctor or the owner of the practice needs, it's there usually within 5 working days. It's back home.
I just ordered a tip, and I'll probably get it today because you shipped it out, I think, on Friday, and the last tip that I bought was, you know, 3 days, 2-3 days it arrived. So you're definitely on the ball as far as shipping, I can tell you that.
Well, customer service was always the main focus of a hygiene-based company. We know what the clinician needs, and, you know, we're a great advocate for the dental hygienist. We really are. It can't get any better than us, because without these tools, you know, you're really lacking in your ability to take, you know, have excellent patient care.
And you also do repairs on air polishing inserts or tips, right?
Yep. You know, a lot of clinicians don't really know what they've got. And, you know, these, you know, the CaviJet tips, I have a whole bunch of stuff on my counter here, but the CaviJet tips, And the ProfiJet tips, CaviJets are the long ones. You know, anyone who's watching doesn't really know the difference. And the short ones are, you know, these little ProfiJet tips. We actually rebuild them, and nobody does that. Manufacturers have gone to aluminum nozzles, and aluminum nozzles are quite soft.
Right.
We actually rebuild them with stainless steel nozzles. So it saves at least 40% on the cost of new, and they're expensive new.
Yeah.
As anyone who would look up, you know, from their rep or in a manufacturer's sales book would see. So we can absolutely rebuild air polishing nozzles, all types, beyond manufacturer specifications.
Yeah. And what about diamond coated tips? You guys do that, Madalyn? Or
I personally have elected not to introduce that into our inventory because of liability reasons.
Okay.
You have to be really
good and careful.
I'd rather the doctor uses those, God forbid. You know, I wouldn't want a dental hygienist. Usually that's undertaken during a surgical procedure. So I
never tried one myself, so I have no idea how much they really get into the tooth structure or anything, but as far as, you know, if you get too aggressive with it. But
I would feel as though a periodontal surgeon doing therapy on the root surfaces, the cementum, would want to use those when there's a flap situation. So I felt as though it would be a very small percentage of sales, and there would be liability if not used correctly. So if I don't use them, you know, I'm not going to be able to represent them.
Yeah, exactly. All right, Madalyn, so you started the business in 2004. What were the primary reasons for that? I mean, what was missing in the market, would you say, mostly at the time?
What was missing in the market, I felt, were extremely high quality external water delivery inserts. Everything had sort of gone to plastic resin handles in the name of ergonomics and internal water delivery. Nice idea, but I didn't see that the water delivery was off the tip of the insert, Mark. I really felt as though I wanted to, as a clinician, and being so many years in perio, I knew I had to get as much water for cavitational benefit to not only debridement, but the tissue off the tip of the insert. And an external water delivery tip that is designed right, a finely beveled nozzle placed behind the bend of a tip that does not cause any tissue impingement. I couldn't find those in certain, you know, manufacturers. And the plastic was cracking, leaking, and didn't have any durability or longevity from what I was used to using of Tony Rizzo's inserts. So, and I also service wasn't there, you know. Units should be tuned up. They need periodic maintenance, and no one was doing that. So it was really quite, you know, lacking in the market.
So would you say, Madalyn, that the other manufacturers were doing these things like adding plastic and other material? Is it mostly you think, to save costs, or is it more of a comfort, like adding comfort to the tip, or what do you think? I mean, what's the...
Well, I happen to know one of my courses was the evolution of ultrasonics, and I lived in that era. So Dentsply Corporation bought out the Cavitron Corporation of Long Island City in the late 70s. And because of certain, I would say, political moves, you couldn't introduce new products. You couldn't, it was a tremendous time of inflation. And I won't go into great detail because I want to be very apolitical. So Dentsply found out a way to make a new product instead of increasing its margin on an older product. And they replaced the surgical grade stainless steel with resin handles. And that that really did reduce their price tremendously. You know, it also, they say, reduced not only the cost, it reduced the weight of the item, but it put in a built-in obsolescence. Anything plastic is not going to hold up to a surgical grade stainless steel. So that was, you know, how resins came about. Originally, it wasn't the comfort ergonomic grips that you're seeing today. That evolved. All the swivels, the LED lights, all the bells and whistles. The clinician is the one that actually makes the insert effective.
Mm-hmm.
You know, I've seen a lot of gimmicks come and go over the years. It's how does that insert perform in the hands of an experienced dental hygienist?
Yeah, I'm a big fan of simplicity, Madalyn. I don't like to me, like having the light on the tip. I mean, I have a headlight, I have loops. I don't need that light at all.
Exactly.
So why would add it to that and, you know, increase the cost and complexity and things to break? And it's like, to me, it's a waste. But
with your headlights and your loops, just like I do, that's your best for ergonomics and vision. When you start adding things like LED lights, people don't realize we're using low power. There's a low light source. If you turn the power up, the light gets brighter. People don't realize that. These bulbs burn out. It adds weight and bulk and, of course, expense. And we get them back through our recycling program by the hundreds. We really do.
Yeah.
They're actually broken apart and recycled. That's where most of them wind up, unfortunately.
yeah,
For the manufacturer.
exactly.
And the clinician and the doctor that purchased it at a high number.
Right. My experience so far with your inserts, Madalyn, I've only had them for a couple of weeks. I bought the P50 universal and the P100, the thinner tip, perio tip I call it. And I just get the triple bend that's not in yet. But so far, I was like super impressed by the water flow. That was the biggest thing, because I've always used internal tips for the most part. I recently got one from a different brand that had the external to try it. But yours is like night and day as far as, like, yours is like close to the actual tip. So it's like, it flows like beautifully. And,
Thank you.
and as far as like power and vibration and how it feels, I mean, it's really good.
I have extremely high standards. I mean, if I'm going to stand behind it, it's a company. I can't compete with the big boys, Mark. I don't want to compete with the big boys. Like you said when we started talking before the interview, it's a small hygiene run, you know, based business. We are passionate, you know, about what we do, and we are very passionate about the quality of our inserts. So when we hear things like your review just now, it's what we strive for. It really is. And we're continually tweaking. We take feedback from clinicians all the time, like yourself. And I'd love to hear what you said about the water delivery system. You know, it was very important for me to have a extremely beveled nozzle that was completely flush with the back of the bend, behind the bend, so there'd never be tissue impingement that would effortlessly bring water right to the clinical attachment area right off the tip where you're using it. It makes your work easier. The more water to remove a deposit, the easier it is.
Don't you find it amazing though, Madalyn? I find this amazing that there are so many products, because I do a lot of product reviews. There are so many products out there on the market that have been being sold for years that stink. Like, they don't even really work, you know?
It doesn't surprise me anymore. It used to, and I would shake my head when I'd have, it's just, I don't know if people now, it's a different generation. They look at price point. They don't look at quality. I don't know, you know, when you're going to, I hear this from dentists now. And of course, you know, when you're going to dental school, you're in a dental hygiene school, a lot of the large manufacturers literally give the dental schools all the products that they need. So they're going to give them the plastic or resin handled instruments. They're going to give them internal water flow. And this is all they're going to know, so that when they come out, they're giving them, go beyond ultrasonics. They're giving them lasers to use. They're giving them CAD CAM products to use, so that they only know that equipment.
Right.
So they come out of school, and from their experience, that's what they stick with. It's hard to get people to change. It's hard to get people to believe that you can go back to an era that is still very much in play today, of extremely high quality, durability, and longevity. And that's what we've strived to have. You know, I get back inserts all the time for rebuilding. You touched on rebuilding. We do rebuild instruments. There's a lot of practices out there that, you know, they don't have the income to buy new inserts all the time. So we rebuild inserts. It's some offices won't do that. That's when we, 8 years ago, I think we were the first. I said, why don't we recycle? I was always big with recycling, and we can do that with our instruments. We have a recycle program. You can send us any brand, any style of ultrasonic insert, any manufacturer. It could be in pieces. I don't care. We'll give you a $10 trade-in credit towards one MadUltrasonic insert. It's a 1-for-1. Just like you bring your car in, you trade in your car, you know. So we get them back, and we're getting back very, very poor quality. A lot is made in Asia. A lot is plastic. A lot don't have certain qualities that our inserts have. But, you know, I see the codes on them, and they're almost, you know, they're very new. In fact, I understand some manufacturers have an automatic ship program every 6 months now, because they know their inserts are only going to last 6 months. When we get ours back to rebuild, it's 6 years. I mean, that's great about our business, and that's not so great about our business financially. Yeah. We make a great product, we rebuild, we recycle, but our hygienists are working with these instruments far longer than they are with our competitions.
Madalyn, can you guys rebuild other brands, or do you just recycle them, basically, like the material? Like, what do you do with them?
We actually are only able to rebuild the P-type inserts.
Okay.
The all-metal external water delivery inserts. Everyone, you know, if there are other people that say, oh, I'll rebuild your every style they have, they're not actually doing that. But we are rebuilding the all-metal P-type inserts. The other styles, we're doing the recycling program with.
Okay. All right. Let's see. I was gonna ask. So as far as like, oh yeah, the price. I would say the price too, Madalyn. Like the price point that you offer is really good. You know, rebuilt inserts are about $85, right? Most of them, right?
85. That's correct.
And then new is $115.
Yes.
You know, tips range from, I've seen like super cheap tips that don't even work, so they don't even buy those. They're like, you know, can be as low as like $70 and all the way up to, I don't know, 160, 170, right? It's a pretty wide range.
About 180. Yep.
Yeah, yeah.
They go up 5% every year.
Yeah.
From certain manufacturers, yes.
I bought a scaler like, I don't know, like a year or two ago, and it came with some free inserts that were obviously like cheap ones, and they cost like $85. They didn't even do anything. You know,
they don't vibrate.
They don't vibrate. So I basically tossed them like right away. They were like worthless. So again, there are so many worthless products out there, and your price point is just really good. I mean, that's.
Well, thank you. You know, we don't have a huge overhead, so that makes our price point lower. You are dealing, we are assembling, you know, all the parts here in New York. So, you know, they're not coming from Asia. And it's allowed us to keep our price point very competitive. We get back for our recycling programs all these inserts you're talking about, all these freebies. They're, like I say, I can see the coding on their stacks, and you know, they are, manufacturing's gone overseas. We know it has. Mm-hmm. And there are, you know, nobody's testing them to see if they're coming back into the clinician's hands actually functioning. Mm-hmm. It's sad.
Yeah.
Making us much busier, thank God.
Right, yeah, that's true. So you mentioned, Madalyn, about tuning your scaler, like it can be out of tune, or you can like adjust like the range or something. Because I was reading on the website about you can like lower the range so it's a little bit maybe more comfortable at the low end. Can you talk about that a little bit?
Absolutely, Mark. There are many fine manufacturers of ultrasonic units on the market, and some of them have different power ranges. You're using a Parkel, I believe.
Right.
Some of those units, different styles or models, have more higher end power than, let's say, a Dentsply SPS, which has that blue low power range, or a Microson that has nice low power range. There are some units that the clinician finds for their patients, the high end is just too strong. And they can be retuned. A lot of these units can go into our technicians, and you can get a broader range of power is what they do. So the low end is extended, so there's more comfort for the patient. Because we like to tell everyone to start with our inserts on the lowest possible power, because they have a broad range of, it's called amplitude, the movement of it. The amplitude is longer, so you're sweeping, you're covering more surface area. So we like low range of power so that amplitude is effective. The higher you turn up your power levels, the shorter the sweep becomes. It's just, you would be able to explain that. You understand that. It's the typical clinician, they just want to put the insert into the handpiece, step on the foot pedal, they want to just go to town.
Right.
They don't want to know any of this stuff.
I personally barely go past half. I mean, if you have a really fresh, good quality insert, I mean, you don't have to have that thing maxed out probably ever. You know, I don't. And for me, it works.
Well, you're a practicing clinician that pays attention. I would rather replace an ultrasonic insert. As it wears, there is a loss of activity to it, so you have to turn up the power to make it work. It's like a pencil, you know. If you have a sharpened pencil, you can use very light pressure and you can write beautifully. You know, that pencil goes down and down, down. You know, you have to place more pressure on it, and you have to have working tip to be effective at removing calculus and biofilm. So I much rather would have a full length or a very minimally loss of tip wear and an insert to be replaced than keep the unit turned up on high power and that need, you know, to be overhauled completely. That's a much more expensive proposition.
Yeah, exactly. All right, Madalyn. So let's kind of get into just power scaling in general. We already kind of got into it already, but so I want to just throw a couple of things at you. The standard insert versus the triple bend. What's the difference, basically?
Well, the universal inserts, the P50, which is just the workhorse of your armamentarium, I think it's really been underrated recently because everyone's gone thin, 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 perio, 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 but you have more of a working diameter. So we've turned that into a triple bend. Some people like more of a work surface. So by that last bend, a triple bend, I mean, I have them all here on the counter, you can really come in contact with the tooth surface. You can use it flat, which you'll see, and you can almost use it like the Beavertail. I don't know if you ever used a Beavertail.
I haven't, but I want to, actually.
I mean, these Beavertails, the P50 and the Beavertail is so utilized. I don't even think you can see them really because I can't, you know, get up too close. But the Beavertail has that nice flat back, and these used on low power ranges. This is what I use on all my pedo patients. We call it, they love the fact that it's called a Beavertail. They associate it with the animal, and it doesn't come to a point. You can't injure tissue with it. So you know, everyone says, oh, that's an old style instrument. Well, it was one of the original, but we've modified it. It's thinner, and it's works on very low range power. So the triple bend evolved from really the Beavertail. Give the clinician a thinner tip insert, but let's give it a bend so it really accesses linguals and interproximals of anteriors. It's really can be universally used all over the mouth because we're using them behind even third molars, but it gives about 3 to 4 millimeters of a flat end of a tip that you can just hold parallel to the tooth surface and just sweep the area. So there's a lot of the tip that comes in contact with the triple bend P1000.
So for like, say you had a lot of stain on the linguals of the lower anteriors, is that something like that then, you're saying, Madalyn? Like you kind of get more surface area?
Yes, you can. I would pick up a Beavertail first, though, to be honest with you. Yeah. And the back of any ultrasonic insert, the P100, the P50, the back of any, you can just use the back of it with plenty of water and you'll get contact. You know, the consummate clinician, anything you do for a long period of time, you can adapt anything, anywhere.
Right. Yeah.
So the triple bend is very cool. We have clinicians that will only use that. They get used to it. It's great. I like to be versatile, and that's why we have the inventory that we do have. So
does the triple bend itself decrease power, increase power? Like how does it affect the power of the insert? Does it do anything?
I would say it's just about the same.
Okay.
It is actually our P50 insert, our universal, which we modify by using a special tool, and they're all made by hand. These instruments are all assembled and made by hand, and every insert that leaves before it's actually shipped is tested by me, which, you know, I run it through a series of tests and tweaks, and if I'm happy with it, it gets shipped. If I'm not, it just gets put in the recycle box.
So the triple bend basically starts off like the P50, and then it gets bent and flattened a little bit. Is that what happens? Yeah. It
gets 3 bends in it, and the angle of that triple bend makes it, you know, much easier to access linguals. It really does. And facials, you can bring the whole flat, like I said, last third of the bend of the tip, just parallel with a tooth. And like you said, if you've got stains, if you've got biofilms, if you've got, you know, calculus, you can just sweep it.
Yeah, very good. All right, so next thing, Madalyn, is power scaling versus hand scaling. You know, some people out there say you don't have to hand scale at all. Some people say you have to hand scale a little bit. A lot of dentists don't want their hygienists to hand scale, waste time, just power scale. What do you think about that concept?
It's really a personal and sort of generational thing. Mm-hmm. I believe that it has to be a blended method. I would say that power scaling is your first line of debridement. It is, even if it's just soft debris, if it could be, you know, food debris or biofilm removal, I would still use ultrasonics. I would finish that up more of exploratory than working with hand instrumentation. As a clinician, you know that when you take your hand instruments, you find areas, maybe spicules that you've missed of calculus. And also that's where you could find, you know, decay, you know, areas that need restorations. So personally, I can only explain it from a personal standpoint. I use a blended. I would say 75% of my scaling is done with ultrasonics. I get the best tissue results from them, you know, because of the benefits of cavitation, well, therapy, and irrigation, of course, is so much what that is. And I'm not using a bladed edge, so I'm not traumatizing the tissue.
I'm the same way, Madalyn. I would say 80-20. It was pretty much the same thing.
It depends on the patient, right?
Yeah,
Mark?
exactly. Yeah, I try to push it too, because a lot of hygienists sometimes, if the patient doesn't, at first they might say, you know, what's that? I don't like that. I don't like that, you know. But it's like, well, give it a try, you know. And I usually win them over because I'm like, if you have a lot of calculus, I'm not going to hand scale all this. You know, not me.
You want longevity of, you know, your professional practice, and you just don't want the musculoskeletal issues that'll happen after a number of decades. You have to rely on your ultrasonic scalings. You really do.
Exactly.
And it's not only dentistry, you know, there's clinicians that think we're only using this in dentistry. Medicine and in industry had been using ultrasonics as their main debridement therapies for decades longer than we have. And in the most high-tech medical treatments, they're using ultrasonic debridement coupled with antibiotics like we would with our, you know, chlorhexidine rinses. They're doing diabetic, you know, wound healing debridement, burn victims, ultrasonic debridement. Firsthand, my husband just had a total hip replacement in January. They debrided the entire area with ultrasonic therapy and antibiotics. This is an important science that if you're not using, you're really, really doing a disservice to your patient.
Absolutely.
What we have in our hands is more than scaling.
Mm-hmm.
It's the weapon against, you know, bacterial colonies. So it is necessary. It really is.
I agree. I'm with you.
Thank you. We're together.
That's right. All right. So next thing, Madalyn, is magnetostrictive versus piezo. Do you have a preference? Do you think one is superior than the other? Is just, you know, what do you think about that?
They've both been around for a long time. Originally, piezo was more of a European debridement process that was started over there. I am very partial to magnetostrictive. They both do the job. They both will debride our tooth surfaces on our patients. It's like a car, you know, there's different qualities, there's different methods of transportation. I love the fact that magnetostrictive scalers have an active 360-degree working surface. I can use any side, it is active, it debrides. Piezo, which most of our clinicians don't know, they think it's newer technology. It is not. Only the lateral sides work. It takes a lot of, you know, to acclimate to it. When I only have 2 working sides, that's a waste of my time and my clinical energy. I think that they say don't use any water. You use very low water with piezo. I want the benefits of cavitational debridement therapy. I want those billions of bubbles to expand and then implode and break cell wall layers. I want to be as antimicrobial as I can. I want to use at least 50 cc's of water per minute. I will get that with my magnetostrictive scaler. I will get a 360-degree working surface with my magnetostrictive scaler. They're much easier to maintain the units, and they last a lot longer. So yes, I'm biased to magnetostrictive, but a piezo will work nicely. I just know how they're built from my technicians on the inside. I know where they're being built now. You're better off if they break to go buy a new one for $500. And then if they break, you're better off going and buying a new one for $500. With a magnetostrictive scaler, you can repair it very easily, and they should be working beautifully in your practice for decades.
Cool. Again, we agree, Madalyn. Huh?
And the little tips that, you know, for the piezo units, those little tips, they're surgically grade stainless steel. I hope, you know, we get them back too. When we go to recycle them, many times they are not stainless steel. There are a lot of off brands there. They charge a fortune for them, probably more than we get for our magnetostrictive complete inserts. They're frequently lost. You need a wrench to tighten them. To me, I think Magnetostrictive is effortless and much more effective.
I agree. In my first office, Madalyn, right out of hygiene school, we had a Pro Select piezo scaler, which is one of the expensive ones. It was a nice one. I was told that that one is the exception, that it is active 360. I don't know if that's true or not, but I mean, but piezos, yeah, in general, just the lateral sides for the most part.
I'm sure you get power on the curvature side, the convex and the concave side, but it's not as active. You're not getting the amplitude that you would on a magnetostrictive.
Yeah, exactly. Next thing, manual tune units. Madalyn, I never try one. I've heard things from people that they're pretty good because you can adjust, basically manually adjust, the settings. So what do you think?
You can actually take it out of what they call phase, and you can use it on such a low setting and still have an active tip, and the patient is, super comfortable. I mean, they don't even feel it. So I have used manually tuned units. They're very hard to find. Parkel does make one that gives you the option. You're in control. You're in control of the power ranges, and that in turn the amplitude, and you can make it very comfortable for your patients. If you're using maybe an insert that isn't really high quality, that has, it's more of a, for lack of a better word, a jackhammer type that really needs a lot of power to be active. Some of the ones that we're seeing now that are, not as high quality, you do need to pump up the power. So if you have a manually tuned unit, you get more range of power in it. You can, it's good. You're dealing with now the amplitude, the power, yourself. You're not just putting an insert into the handpiece and the unit's reading that precise frequency of that stack. The stack is the what you insert into the handpiece. There's a stack. These are nickel laminates, and an auto-tune unit. You put this in, you step on the foot pedal, and it reads the frequency perfectly. Just because this is a 25K insert doesn't mean it vibrates 25,000 elliptical cycles per second. It might vibrate 21 or 26. In a manual unit, tune unit, you would be able to have that variation of where you want it to purr, so to speak.
What is the practical difference between a 25K and a 30K from the clinician's point of view, like feeling it? What are they going to feel different?
It's really imperceptible. I can tell you, we can go back to the late 70s when Dentsply did buy out the Cavitron Corporation. They wanted actually to make all the instruments obsolete. So originally in the 60s, when the technology for using ultrasonics in dentistry was developed, the optimum, the engineers, the scientists, they all agreed 25K, those 25,000 elliptical cycles per second, ultrasonics beyond the sound of the ear, human hearing. We hear it, it makes a noise only because water hits the tip. No water, no sound. But people hear that buzz sound and it's the water, but you need water so that, for many other reasons, that's a different question. The Dentsply Corporation wanted to make the instruments obsolete. They decided, could they make a unit that operated 25,000 elliptical cycles faster? They were able to do it. They reduced the length of the stack by about 1 inch. Now I have them here. They're, I don't know if you can see them. There's about 1 inch difference in the lengths of these stacks. So they saved on, the metal. They made an instrument that was new. They said it was better. It was more powerful. It wasn't. It just had 5,000 more elliptical cycles per second. And to this day, the consummate hygienist, clinician periodontal surgeon, they demand a 25K instrument. They feel as though the sweep is longer, covers more tooth surface, and they're right. It's more comfortable for the patient. It's not hammering as much.
My experience, Madalyn, is the 25K seems to work a little bit better. I don't know if it's because all my units that I have are basically, they take both tips so that it's auto adjust to whatever tip's in there. So I don't know if it's because you have the extra space in the handpiece or the handle, you know. I have no idea why, but to me it just seems like my 25Ks work better. They're slightly more powerful than the 30K. But that, I mean, that's just me. I don't know. It just feels that way.
You're absolutely right. Originally, when all this science was done, back when all these engineers came back from service during World War II, we had all these engineers that were working, you know, in Long Island City for the Cavitron Corporation. They optimum frequency for using on a tooth surface was 25K. The sweep, the amplitude was just the right amount, the comfort level for the patient, and all these things you said. So I don't think that the 30K changes things too much perceptively to the patient or, you know, clinicians, unless you really are attuned of what you're doing and have a lot of experience with it.
Exactly. So I'm just going to stay with 25K.
I think you're a smart guy. You're in the leagues of the consummate clinicians out there.
I have a couple of 30Ks. Just I have like the exact same insert, same company, you know, and I noticed, I mean, that's where I noticed the difference. So there's no difference. They're both new. They're both the same, you know, brand and everything. So 25K for me all the way.
Good for you.
All right, Madalyn. So what are some of the common mistakes hygienists make with power scaling? The notes I have is like worn inserts. You know, they keep using worn inserts and whatever, you know, things like that. What do you think about that, Madalyn?
Well, I'll go first of all for power ranges. You've gotta, which is just comes into play with what you just said. When you have a new insert, it's active, it has full length of tip. You're getting 100%, you know, efficiency on it. You use this at lower levels of power and coupled with plenty of water. I see hygienists that don't use enough water flow. Water has to cool the tip, which cools the tooth and irrigates the where you're working. Of course, subgingivally cools the tissue and creates cavitation. You've got to have at least 50 cc's streaming off the tip per minute. So when you have a worn tip, you're turning the power up. You're working harder at your job, actually, because the tip is shorter and it's not moving as far. You don't get amplitude from it. You don't get any length of distance working tip. So there you have, you know, you must trade in or you must rebuild to have optimum length of the ultrasonic tip. That's a big, big issue. We get them back. I swear girls are using their fingernails. I don't know how they're using some of these tips. And the use of water. And also, you have to stay in the gingival sulcus or in the pocket. You can't do flyby scaling. Girls, excuse me, hygienists or clinicians, doctors, dentists, no matter what gender they are, they just run it along the tooth surface, thinking they're going to do debridement. You have to always stay moving, but stay in the sulcus, stay in the working area and keep moving it. Don't fly by, keep using it until the water you see that's being irrigated is clear. That means there's no more deposits or no more accretions, no more debris. And I see that a lot of clinicians don't stay on the tooth surface long enough. I don't know if that's something that, you know, you've seen also.
I mean, I've done it too, man. I always constantly tell myself like to slow down. I think it's the natural thing. If you're scaling supra, you can see it, so you see how long it's taking to remove the deposit. Whereas when you go sub and it's blind, you don't know what's going on. I mean, you can't see it directly, so you don't know when to stop in your head, you know, so you just maybe thinking like, okay, that's good. I got it, you know, I don't know.
No, it's true. You know, it takes a lot of experience to be, you know, proficient at it. And it comes with experience. It does. What is that saying? Do something for 10,000 hours and you're a expert at it.
Right. Yeah.
I really think it takes a number of years of ultrasonic practice to actually get the feel of it. And every mouth is different. So everything is, that's why I do pick up the hand instruments and go subgingivally to make sure that I've been effective. And then what I do is I pick up my ultrasonic scaler and go back and do the debridement 9 times out of 10. Because I feel as though that's more effective than hand instrumentation.
I've been a hygienist for almost 9 years, 8.5 years, and I still feel like I have plenty of room for improvement. Like, to me, like scaling sub, you know, blindly most of the time, that's a skill that takes many, many, many years to be good at. And I think a lot of hygienists kind of just plateau and never, you know what I'm saying? I don't know.
Yeah, absolutely. There's so many things you do with ultrasonics that people don't realize. You can curettage with ultrasonics. You can go ahead, not only stain removal, because I found that not all stain is tartar, but all tartar is stain. You know, a lot of times, you know, I had 20-something years ago started selective polishing and would polish a mouth first. Being in the perio practice, we had a lot of medically compromised patients, even heart transplant, kidney transplant, you know, what you can imagine. And I would say, well, let's get rid of all the active bacteria, plaque as we call it back then. I would polish first. There was plenty of stain still on the teeth. And I knew that I had to use my ultrasonics for stain removal. It wasn't stain removal I had polished. This was removal of calculus that a lot of clinicians will do all their ultrasonic scaling maybe, or maybe their hand scaling, and they'll say, oh, I'll catch that stain later. It's still there after they polish. Well, they've left calculus. So, you know, you can do a lot of things with ultrasonics besides debridement. You know, you're removing your biofilms, you're removing your hard calculus, you're removing your stains, you're delivering antimicrobial medicaments. You know, you're going ahead and curettaging. You can remove overhangs. You can smooth out, you know, sometimes a amalgam restoration. You can do that. You know, there's countless things you really can. It's very good for the tissues. I don't think we utilize it enough. You know, we really don't. And we don't actually get to the base, the clinical attachment area. I think hygienists are afraid to put their ultrasonic insert to the clinical attachment area. And the beauty of ultrasonics is you can work coronally to the apex. So you work your way right down from the incisal or occlusal edge down into the base of the sulcus. And usually before you get there, the deposit fractures.
Right.
So it's a great instrument.
I can't imagine. I always mention this, Madalyn, like, you know, hygienists like yourself that have been doing it for a long time. You talk about, you know, 40 years ago, just hand scaling. I would just kill myself. You know, I couldn't. I wouldn't want to do it.
I was really blessed getting back to going to work in 1976 for Dr. Morton Rosenbluth, who has been my father-in-law. You know, I was very lucky. It's a great story, but not part of what this is about. This is personal. That's personal. Was very good friends with Tony Rizzo, and we always had ultrasonics in our office. So I always was exposed to using the Cavitron. So, you know, we were lucky. We had one in every treatment room. And it was my father-in-law really pushed it. He was an implantologist, periodontist. We were working on implants in the 70s. So I learned so much from him. It was really a tremendous way to start practicing hygiene, I was never without an ultrasonic scaler.
And as far as like worn instruments, Madalyn, when I got my inserts from you, it came with a little guide. You can test, if it's worn out.
The efficiency indicator.
Yeah. So I'm guessing a lot of hygienists out there are using worn instruments because, one, they don't know if it's worn or not based by just looking at it, right? And maybe a lot of their employers don't want to replace them as often enough. So I think a lot of hygienists get the idea that the power scaling is not as effective that it really is, and with a good brand, good, new insert and all that. And they kind of rely on hand scaling too much because of that. So they almost have like a bad experience basically with power scaling, which they really shouldn't have.
You're absolutely right. In any profession, you need the right tools to be the best professional you can be. If you're building houses, if you're building, anything from a car to being a clinician, or even the dentist should understand, he wants to purchase the best diamond burrs. He wants to purchase the best equipment to be able to practice his profession. And when wear comes into play, they have to be replaced. And a lot of times the nature of the dental hygienist is very submissive. They don't ask for a lot of things. And they don't know, like you said, Mark, that inserts are worn until you place a new one next to them. And then they go,
oh,
OMG, they don't realize it. And once you educate them to the ergonomic value and the value to their musculoskeletal system and their whole practice, the finer quality, the better the product they're using. It could be from the hand scalers to the ultrasonic instruments. It's making it effortless for them. It's making it more effective for the patient. I would think the doctor, the dentist, would want to have the highest quality instruments, supplies, everything across the board for the patient care. And that's how I always tell the hygienist, present it to the boss, don't you want our patients to have the highest quality? And it's very hard to argue with that. And you're not even paying an exorbitant amount when it comes to our particular products. You're paying a very fair, competitively priced amount.
So with that said, Madalyn, I'm a big advocate for hygienists to buy their own instruments. What do you think about that? Because I always say, look, sometimes the employer is just not going to be convinced for whatever reason, multiple reasons. Maybe, the budget is tight and all that kind of stuff. Just start off with a little bit, a couple inserts, every year, it's not a huge expense, it's, you spend like $500 a year, maybe $1,000, you can get a lot for that,
Well, I try and encourage the clinician, the hygienist, you own your profession. You really are. This is what you do on a daily basis. You have to invest in yourself, just like Mark, you said earlier, loops and light. If you don't work for one of the practices, it's going to go ahead and invest in that for you to use on the practice's patients. You have to do it for yourself. If you want the longevity of your career, you have a great career. You're a primary care oral health care provider. We've got to start elevating ourselves. I had mentioned what I have done in form of hygiene and in form of, MadUltrasonics. I've always been a member of the American Dental Association. My New York component, DASNY, and my local Westchester Dental Hygiene Association, when I'm licensed in 3 states, always in Florida. I was always very, very active. We have to advance our profession. And we have to have the personal self-esteem to say, if my boss is not going to invest in instruments for our practice or his practice, we have to take it upon ourselves to invest for, ourselves. It's, I'm seeing it more and more. I never used to see this 4, 5, 6 years ago. It was unheard of hygienists purchasing their own equipment. But times have changed. And it's sad, but it's because the profession is, the clinician, I think, is so undervalued. Maybe that's, you know, our fault. You know, I'm talking from, you know, what I've talked to hygienists about, and this can go off on another tangent, but we do have to elevate ourselves. We are going to be performing not only the oral cancer screenings, besides the perio screenings, we're going to be doing saliva testing. We're really the primary care oral health care provider. And I think you're going to see the status, the level of dental hygienists just go through the roof in the next decade. And with this, you know, hygienists are going to have to invest in themselves, in their workplace.
Yeah, I agree. I think, I mean, hopefully the trend is very slow, and it's a lot of, you know, negative feedback, I guess, from the dental profession. But, you know, the hygienists are slowly getting more independent. Like, more states are having at least public health hygienists, and the advanced practitioner thing is kind of spreading a little bit, you know. So I think that's, go ahead. Yeah.
Collaborative practice has been passed in the state of New York. These are first steps to getting to populations where are so underserved. I mean, that should be the ultimate goal of the profession of dentistry, is to serve the population with oral health care. The hygienist is the #1 resource for that. Utilize it. So
yeah, to me, it's a win-win too, Madalyn, because I always think of, like, I picture like hygienists being out there, even if we're doing, you know, prevention, education, and doing the things that we can do now out in the field in different ways. Well, if that patient needs you know, restoration, extraction, or dentures, whatever, we're going to refer all these people to dentists.
We're going to drive them right into the chairs of the dentist. We don't, you know, we don't want to do that. We're not qualified to do that. We're preventive specialists. Send them to the restorative specialist. There's no competition there.
Exactly.
I agree with you.
You know,
so there's no threat. We're no threat. I know that.
Personally, man, I mean, I'd rather see hygienists buy their own instruments. I know it's maybe a kind of extreme view, but, and I'm not trying to compare us to auto mechanics or plumbers or whatever, but you know, they have their own tools. You know, they're expected as in their profession to buy their own tools. Like, as hygienists, we all have preferences and what we prefer, and so I don't like the idea of like one size fits all. Like, okay, the one employer is going to buy a bunch of instruments for everybody, and just, you know, it should be fine for everybody. You know, we all have different preferences as far as instruments and products and everything. So I'd rather see like hygienists maybe getting paid a couple of bucks more an hour, and then be responsible for buying all your inserts, all your hand instruments, you know, all those kind of things. But that's just me.
No, it's a great idea, and I see it happening in several offices. It's hygienists get, you know, a budget of so much per, let's say, quarter or year, and they can go ahead and purchase it, sort of what they need for themselves. Even though in the back of our minds we are, you know, salaried employees, we're not independent contractors. It's a catch-22. You know, there's many sides to this story, but ultimately, like you said, Mark, we are the professionals, we're the clinicians, we have different preferences. One size does not fit all. We should be allowed to use what we feel treats the patient in the most optimum, you know, way.
Exactly. So I have 2 more things, Madalyn. The air polishing. What are your thoughts on air polishing in general? I know most hygienists don't use air polishing. I do. I have one of those cheaper air polishers. I use it for ortho patients, you know, mostly. I use it for like cleaning the tooth for sealant, stuff like that. So what do you think about air polishing in general?
I think air polishing is great. It's underutilized. It is been around forever, and people may not realize it. It's excellent for implant care. You have to use the right, you know, product too. I don't use anything with silicate, you know, that's not natural. So that's another area that we, you know, could discuss at a later point. I love air polishing. I'll do it first on an ortho patient or a patient that has a tremendous amount of soft deposits and or stain. You're absolutely right. And here again for implants, it's optimum use for debriding biofilms from implants, and then you can go in there and use your ultrasonics.
Yeah, there's some products out there that have the subgingival air polishing. I haven't tried any of those yet, but
there's a lot of new. Yes, they have the perio tips that will insert subgingivally. You're absolutely right. They're, Cavo has always had a really great. I've used a Cavo air polisher for decades. They always made a great. They're a German company. They have a very high quality product. All their products are really, I think, great. I have, a Cavajet at the office I work at. I love Dentsply's Cavitron's SPS Cavajet. They're really great units, and we're always using our Cavajet nozzle to go ahead and air polish. Patients love it.
Mm-hmm.
They're comfortable with it. They love the sodium bicarbonate. They feel they feel great. But here again, it's underutilized, but it's something for the professional to look into, to purchase for themselves. They can always get it on a trial basis from a number of manufacturers, see if they like it.
Mm-hmm. Exactly. And left and right inserts, Madalyn, I have some from a different brand. I don't use them that much. I use them every now and then. But to me, they just seem, maybe it's because of the brand I'm using, I'm not sure. They just seem kind of weak because they're like really long. But so what do you think about that? Like having left and right, is that absolutely necessary, you think? Or
I think it's not absolutely necessary to have it in your armamentarium unless you're in perio. I think if you're working in a perio office, it absolutely is. A lot of our clients that use perioscopy, order them exclusively.
Mm-hmm.
So it depends what type of practice you're in. Lefts and rights can get you into areas that you won't normally get into. With I would probably pick up my lefts and rights probably about 5% of the time. I think if you have your universals and you have your general practice patient, it's not necessary for a left and right. But if you are doing perio work, yes, I would think the lefts and rights are very important. Ours, you probably think the tips are longer. They're not. It's just the angle of the bend that makes them appear longer. Mm-hmm. We like to test our lefts and rights before they get the bend in them, make sure they're at optimum frequency and amplitude. Then we, all by hand, place the bend in them, align all the water nozzles for optimum water off the tip. That's another problem with a lot of lefts and rights. You're not getting enough water streaming off the tip. That makes them a lot less active for your working. And then we just go ahead and absolutely make sure they are working at the optimum frequency and amplitude. And then, only when they test, my testing of them, they pass the test, they go out. So it could be someone's manufacturer. They are very thin instruments. They're not necessarily very delicate ones, but they are very thin. So you really have to have a very good visual field. I would say you need your loops, definitely. You need illumination from an LED headlamp. You really need to see where that tip is hitting the tooth.
Mm-hmm. Well, my plan is to try every tip you sell eventually, Madalyn, and then I want to slowly replace the ones I have with, my workhorse is going to be the P50, I'm pretty sure, and then go from there. I want to try every single one, Beavertail, all that.
Oh, that's great. And our implant scaler, I don't know if you've seen that. That was developed. People don't even know it exists. We developed that in the early 90s. The funny story behind it is, I'm sitting there, and of course I'm clinically working hygienist, and I'm a woman, and I hated how the guys, the engineers, wanted to make this snap on with a tool. I was wearing an earring, you know, fortunate enough, it was a diamond screw back earring, and I took it off when I go, it needs to be this. And then it was the light bulb went off. And this is 22 years ago, Mark. And I said, you know, let's make it like the screw back of an earring. You don't need a tool. You have an insert with a proprietary threading on it. It lasts forever. This can only be used with this blue, you know, little tip. I don't know if you can see it,
I can kind of see it.
There it is. And this works as a disposable blue tip, and you just screw it back on. You don't have to run around the office and find who's got a little tool. Make sure it's secure, and you use it and you sterilize it in place. It depends if you're using it. I wrote an article, I believe 10 years ago on this, called The Multiple Modalities of the ITS Implant Scaler. I use it for ortho patients. I use it for pedo patients. I use it for patients with abfractions, gingival recession, you know, any sort of sensitivity. It's a zero sensitivity scaler. So that's a great tool that's very underutilized. We call it our implant scaler, but it can be used for all of the above. I guess I was a little ahead of my time on it, but you know, it's a very versatile instrument also.
I will definitely try it at some point. So last thing, you already mentioned a little bit, Madalyn, about the Perioscope. What are your thoughts about the Perioscope? That's something that I've thought about doing for a long time, maybe like as a part-time thing. And the question is, it's very expensive, and trying to create a business model that's going to work, you know. But so what do you think about that?
I personally have not used a Perioscope. I've been in offices, clients that do have it and do use it. I think it takes, there's a great learning curve to doing it. But once you do it, your ability to breed and the patient care that comes with it is just incredible. And here again, I think that it's reserved for periodontal practices as well. I don't know who is currently making a Perioscope. I know they're hard to get access to for purchasing. It used to be there were a handful of companies, and now I don't know of any that are out there. I hope that, you know, I find some that are. The clients I work with have older ones that they're using. I think it'd be, you know, it opens up a whole new world, a whole subgingival world, which is incredible to clinicians that have the ability to spend at least an hour per quadrant working.
Yeah, what I know about it, Madalyn, is you know, Dental View was the original, I believe, and then Dr. Kwan in California bought it, and his company's Perioscopy. And then Danville just, I think, bought it from him. I think he's still working with them. And there's another company too that's in development, because I got an email from the company about it. So I think there's basically two. One's basically out there, like they have a new generation one now, but you can still buy old units too. So the new one is like 20,000 or so. So it's not cheap, you know. But
it's a big investment.
It's a big investment. So I got to really think about it as far as business model. I'm thinking like almost going in as like a specialist in a sense, like going in, just do perio, and then, you know, like bring my own scope, do perio in the office, and then that's it, and get paid for that, you know. But we'll see. I don't know.
Perhaps you can go to the company, get training on it, and see how you like it. You know, they'll send you out into the field as some type of, you know, representative, so you get a feel for it.
Yeah. Yeah, we'll see.
I think it really adds to, you know, the resume, the qualifications. It's really quite an ace in your hands to have that ability to do that.
Yeah, because I'm thinking like trying to find a dentist or periodontist that has it is very rare at this point, you know. So the way to make it happen, I think, is to invest in yourself, and then for them, it's not a high risk because you're buying the scope. But I mean, of course, you have to charge a little bit more to cover your costs and so on and so forth. But we'll see.
most of our clients that are using them are in South Florida. You know, they have, you know, an association with Pankey Institute in South Florida, a lot of our clients. And then, of course, Dr. Kwan, you know, out in a lot of California-based clients that we have. So it's interesting, those schools.
Yeah, exactly. All right, Madalyn. So I think we pretty much hit on all the points I had.
Great.
My plan, you know, like I was saying, I'm going to buy all your inserts and try every single one, and then slowly, slowly replace the ones I have with the P50 mostly. But I'll get the other ones.
I want your critiques. I want your feedback. Oh, yeah. I really do.
I'm probably going to do a product review soon. Just about my general thoughts on the inserts so far, you know, which obviously have been positive. So,
terrific.
Maybe, you know, maybe like do a video of me using it. I mean, even though you really can't see it up close because I use my iPhone, but for the video. But
you know, because we, like you said before, customer service is our #1. We are there for the clinician, the biggest advocate for, you know, you're working and being successful in treating, you know, your patients. So we're always, if there's something specialized you want developed, we do that. We custom make inserts all the time. We go ahead and if something, you know, you want tweaked a little more, some people like more of a back bend, some people like more of a forward bend. There's all kinds of things that we can do because they're all handmade, and we just are there to accommodate clinicians like yourself.
Thank you very much. So what's the best way to contact you? You know, website, email, that kind of thing?
Any way that's easiest for the hardworking clinician. If you want to pick up the phone and call us, you can call us. If you want to shoot us an email, you can do it through the website as well. So we've got all options to contact us. You know, on our website, we have contact us. Just click on it, shoots us an email. My email is Madalyn@MadUltrasonics.com. Don't even bother typing it in. Go to the website, type in MadUltrasonics. It'll come right up. Go to our website. We have everything, you know, listed there. We have some articles there. We have critiques listed there. All our styles are there. And here again, you know, we're always growing, expanding, and listening to our clinicians, you know, and myself. You know, we're in the process of even developing some new things that, you know, the more I practice, the more there's a need for different patient requirements. So it's very exciting. It's extremely exciting to be part of an evolution like that.
That's very good. All right. So thank you very much, Madalyn, for doing this. Stay on. I'm gonna stop the recording for a second. Okay.
Great, Mark. Thanks.
Bye.